So now we begin the next session, which is on precision vision, enhancing outcomes in refractive surgery. So I am Purendra Bhasin. Thank you all for being here. And my first talk of this session will be given by my friend, none other, Dr. Krishna Prasad Kudlu. And he will be speaking on redefining monovision. With me is Dr. Vipul Arora, and welcome. Dr. Manpreet is in another hall as of now. Dr. Rahil.
Thank you, Dr. Purendra, because it's clashing with OPL. Hopefully, I think one or two speakers, but we have to finish our job. So I'll be talking about redefining monovision. So what exactly this monovision? It is a refractive solution for presbyopia. Normally, what we do, adjustment of one eye for near vision and other eye for the distant vision. So why we all picked up for monovision? Because more natural to visual system, easy adaptation, better patient satisfaction, and easy to adapt. But most important thing in any of this monovision treatment is to know the ocular dominance. So there are a lot of tests are there to know the ocular dominance. You can try to do pointing test, shooting stimulation, or preferred sighting of a camera. So normally most of the patient will have a clear dominance or dominant eye for distance and non-dominant eye for near. But sometimes some patient may have no clear dominance. They may have an alternate dominance. These patients are a very tricky patient. So always documentation is very, very important. So coming to the laser blended vision presbyon, it's a examiner based solution for presbyopia with the concept of micromonovision with creating a spherical aberration in the cornea with a good depth of focus. So what exactly we do? We make the dominant eye emmetropic, make the non-dominant emmetropic, myopic by creating the spherical aberration. But you all know that how presbyopia is very important in the practice. Nowadays, most of the patients coming to us that they should not be like, they don't want to wear the glasses. So coming to the pre-op evaluation, who are the patient can undergo presbyon, myopia up to 8 diopter depending upon the PACI value. Even we are doing hypermetropic up to 5.5 diopters. Even we have done around 100 plus patient with emmetropic and astigmatism up to 12 diopters. Make sure that patient don't have any cataract. So this is how normally refraction, I do the cycloplegic refraction. I'll just come back to it. So being my chair time in presbyopic laser refractive surgery is for 45 minutes. Now, I normally ask their ocular history, family history and medications and whether patient is on any allergy also, and also look for any dry eye symptom. Once this is done, then we are normally do the pupillary reaction test, ocular motility testing also, and bilateral pupillometry. If you find any doubt is there, normally I do even a confrontation field test also to know also monocular and binocular visual acuity by the surgeon himself. Once it's done, then next is the refraction. This is very important. So do the refraction. Make sure that it is a duochrome balanced. Once you know or done the refraction, so your job to know the patient's dominant eye. So once it is duochrome balanced, then take out, open both the eyes. Then tell the patient to make a small hole or aperture in both the hand. Tell him to get near to the eyes. When he is getting, normally he get in front of his dominant eye. This is how you check for the dominant eye. Then tell him to take back again. Then try to close the non-dominant eye. If he is seeing when he is closing the dominant eye, suddenly he will tell that he cannot see. That means whatever the eye he is seeing, that is the dominant eye. Once you know that which is his dominant eye, then put plus 1.5 diopters in front of the non-dominant. It's called micromonovision testing. Then with the same addition on in the non-dominant eye, you tell him to read for small letters N5. With the same correction on, I will tell him to read for distance, and if he can read for distance 6.6, and N5 without patient complaining of cross blur. These are the patient really do extremely well after the treatment. There are certain patients, they say that I am having cross blur. Sometimes you may have to repeat this test. Then if they still say that I am having cross blur, these are the patient I am not taking them for laser refractive surgery. Once this is all done, I think of course you have to do the proper indirect ophthalmoscopy, make sure that retina is normal. Then always make sure that all the other tests has been done regularly. So once we do, normally we do along with the vascular aberrometry also, just to know the ZAQ value also. Then once is done, everything the software, before that I am going to do this important test. This is eye trace, mainly to see for DLI, to look for dysfunction lens index. If it is DLI is more, then these are the patient I am not picking him for the laser refractive presbyopic surgery. So as I said that we have to do the vascular analyzer to know the ZDK value. Once it is done, now the software also you can include the functional age, and also you can include the spherical aberration. This is about the software which is in the CRS master. Normally most of the patient, first you have to do both the both the eye refraction. Then once it is done, then plus add 1.5. But suppose the patient is very young age, around 40 years, normally I reduce to 1.25. If the patient is around 52 to 55, then I increase to 1.75. So 1.75 plus some amount of spherical aberration always give the eye of effect around 2.5 in near vision. This is how this software works. Once the data from the CRS method, that has to be transferred into the examiner system. Then procedure is very simple. How you do the LASIK treatment. This is a femto-LASIK procedure. First do under the Visumax, take the flap, then the patient has to be shifted under the ML80 table, where this presbyopic treatment will be done. So most of the treatment will be like the planned by the software only, unless and until if the patient is too old, then you may have to do a little arrangement. So the procedure is as simple as that, how you do any of the refractive procedure. Lift the flap, do the examiner treatment, and put back the flap. So very easy. So recovery phase has got two steps: physical adaptation phase and neural adaptation phase. Normally, for few weeks, the most of the patient adapt very next day. Short-sighted and long-sighted presbyopic, quickest one to adapt. Only thing is planar presbyopic sometimes takes some time. Maximum in my case up to 4 months. So basically we have to treat both the eye, and basically it's a bilateral treatment. Always the results are same. So probably I can say that presbyond is in the best available approach for the patient with presbyopia if the patient don't have cataract. Thank you, Dr. Purendra Basin, for the full opportunity. Thank you, one and all.
Thank you, sir. Thank you. And does the patient has any glare, halo, or any other complaint because of this change in abrasions?
See, we have done a study of up to 1,000 patients last. Not even a single patient had a glare and halos. But your pre-operative workup has to be dead on. Pre-operative workup means if the patient is having a cross blur, repeat 2 times. Still, if he is having cross blur, don't pick them for the presbyopic treatment.
Okay.
But if they are pre-operative, your workup is perfect dead on, there is no glare and halos. And also, you need to have equipment like eye trace and all to know the dysfunctional lens index.
Yeah.
If that says that there is no cataract, then you can. I have done for 68 years old.
Okay.
So, they are doing well.
That is so nice. Thank you for sharing your experience. And may I request our next.
Hello,
is
Dr. Sonu.
Are you
Sir
ready?
will present on CLEX, new paradigm in refractive surgery.
Manpreet has come.
Yeah, you
Okay. Can Dr. Sonu do? Are you ready with your talk?
So, sir can present.
Or you can do the
Yeah,
first.
so you
talk.
can present first.
You can present. उधर तो हो गया इधर चेयरपर्सन और कौन है? मेरे को भी उधर जाना है। नहीं, मेरे को हॉल बॉलरूम 2 में जाना है। जीबीएम चालू हो गया क्या? सॉरी।
नहीं गोइंग ऑन. यस सर, बघत आले मी. जी अभी थर्ड टीम जस्ट स्टार्ट हुई है, तो थर्ड एंड फोर्थ टीम झाले.
को दिखने देवदत्त नायक.
So, a very good afternoon.
वो चेक कर लो वहाँ पर स्टार्ट हुआ.
Dr. Purendra, can I? I'm on? Okay. So, very good afternoon, and I'm talking on CLEX. So, I think CLEX word or LALEX is a new word coined for keratorefractive lenticle extraction. So, now all the equipments based on lenticle extraction, so the common terminology for this kind of surgery is CLEX, and which is a new paradigm in refractive surgery. So worldwide, there has been an evaluation in terms of refractive surgery from PRK to LASIK, wavefront guided, phakic lenses, and now is the world for the lenticle-based surgeries. So this is a major survey done by the ESCRS, and which clearly shows that over a period of years, both the Western and the Eastern Europe, there have been a drift, and it is the femtosecond intrastromal lenticle extraction which is slowly and slowly gaining popularity worldwide. So essentially, when we talk of the key steps involved in lenticle extraction, is this first creation of the base of the lenticule, then is the lenticule side cut. Essentially, this takes around 10 seconds, the side cut around 2 seconds, then is the cap cut around 12 seconds, and the cap side cut, which is close to 2 to 3 seconds. So essentially, within 24 to 28 seconds, all the platforms in the world market create this lenticule which can be extracted easily. So if you compare the various platforms available, ranging from Zeiss VisuMax 500, VisuMax 800, then the Zimmer has the Z8 platform, and the Schwind has the ATOS, and the J&J call it the Elita system. The source of wavelength almost in all these platforms remain almost common. This is 1043 nanometers. The laser pulse repetition rate, which is a major game changer for VisuMax, has been from 500 kilohertz. They have shifted this machine to almost 2 megahertz, which makes this machine much, much faster and much more precise. For Femto LDV, it is close to 20, and for Elita, this is close to 10 megahertz. This is the energy which is quite comparable, but here Elita stands out where the energy delivered is very low. It works on almost 50 to 70 nanojoules. So the heating is less, and it basically may transform into day one clarity. So the laser cut time for us from VisuMax 500 shifted from 30 seconds to almost close to 8 to 10 seconds on the 800 platform, but all these platforms usually take around 30 to 40 seconds. And the patient interface here is a curved interface, and it's more of a corneal limbal docking. So on the 800, we have a cyclotorsion compensation. It has an inbuilt centration. And the most important with Dr. Manpreet would be talking is the Circle software, which is available only on the Zeiss platform. So Circle essentially helps you to treat those residual refractive errors, if you have any, where you can easily convert the cap to a flap and augment using excimer laser. The docking essentially is more of a condyle docking or a limbal docking, where there is no cherry red eyes as compared to the different platforms, especially with Elita, where you have the eyes turning out to be red. So we conducted at a center a small study. It was a retrospective study comparing the refractive and the visual outcomes in patients with myopia and myopic astigmatism, patients who underwent smile surgery using the Visumax 800. So quick description of Visumax 800. It's a 2 megahertz laser system. It's much faster. So essentially the laser time is reduced, the lenticule is created in less than 8 seconds, and the flap is created in less than 5 seconds. Now what is this shorter suction time? Essentially increases not only the peace of mind and the stress from the patient and the doctor, but essentially various studies have shown that the major part of the suction break occurs during the first 15 seconds of the suction. So if the procedure entirely completes within 8 seconds, so gone are those days of suction losses where you retreat or retake these patients after 3 months of the surgery. So, and the second important is the spot spacing from 4.5 to 3 has made tissue separation much easier, and the spot spacing for the lenticule close to 1.5 side cuts has essentially given a very smooth kind of a dissection on the 800 platform. So total we did almost 1507 eyes, and it was around 765 patients. And if you see here, all the patients, the BCVA was close to almost 100%, and there was no drift and there was no shift between 1 week, 1 month and 3 months post-operatively. And the mean spherical equivalent after 3 months post-operative, 99% of the subjects are almost close to 0 diopters, and where 1% of the subjects had close to almost minus 0.5 diopters. The safety index and the efficacy was close to almost 1.01, and the efficacy was close to 0.94 on this platform. The mean sphere that we treated was average was minus 3.9, ranging from minus 0.25 to minus 9.75. And what was more interesting was the cylindrical error that we could treat on this platform from 0.25 to minus 4.5. So minus 4.5 was the max sill that we treated, and thanks to the cyclotorsion compensation, that it still treats bang on the axis. So the pre-op spherical equivalent from minus 4.23 went down to close to minus 0.12. So this is how the post-op graph looked like. And if you see on similarly on the cylindrical error, the mean pre-op cylinder from minus 0.65 dropped down to close to 0.05. So a quick word of the HOA, and I think it is more of the centration, because this device has a wonderful centration system, and by which we could achieve, if you see all in all, drop in the post-op HOAs from 0.31 to almost 0.16. And that's what I think the quality of vision can be attributed to. And similarly, we had the coma dropping down from 0.16 to close to 0.1 post-operatively. Talking about the spherical aberration, the pre-operatively 0.02 plus minus 0.03 went close to almost minus 0.2 plus minus 0.7. So we all know that the biggest bug is the suction loss in all these procedures, and we always have this frame fitted into a mindset where we essentially want that most of the suction loss should occur once you have a lenticule side cut. But what if it occurs before that? So essentially, if the suction duration is close to 8 seconds, so gone are those days where we actually need to convert the cap to a flap. So all in all, out of, I'll just take one more minute. So 1507 eyes that we did, there were only 2 patients who had suction loss, and these 2 patients were typical hyper-neurotic kind of patients who were, difficult to make them even enter the OT premises. So I think all in all, the safety profile with this system is essentially what makes this a very robust system. So the centration, if you see here, and so this is how you take the patient and you can ask the patient to focus, and then you can make the infrared camera on and achieve the centration right on the visual axis. So if you see here, this is what is the deviation, and you actually aim for this blue where it is less than 0.1 millimeters. So here yellow means it's close to between 0.1 to 0.2, and this is how the centration can be achieved. And this is the center aligned system on this VisuMax 800 platform. And so we all know that the angle kappa adjustment actually helps in controlling of the HOA, and adjustment of angle kappa during smile actually resulted in the less HOAs, and this is the cyclotorsion alignment. The moment you do the suction, you can actually then, if you see here, so once the preoperative marking has been done, slowly, very shortly we'll have an access to the AIOLMaster 700. If you see here, the moment you can rotate the joystick and then actually press for the ablation to happen. So it's bang on the desired axis, correlating to the 2 marks that you have already taken. But slowly, shortly we'll have this centration on the AIOLMaster 700, which will essentially make it a fully automatic system. So to take home, it has better refractive results. Most of the patients that we have, 20/20 day 1, the HOA, the cylindrical errors, and the cyclotorsion are quite predictable. The suction loss is the story of the past, so it becomes very safe. Patients are very comfortable. The pain and the pain score is almost close to 0, and the vision quality is amazing. It's such a user-friendly system that the workflow is very, very easy. So boils down to less surgical and OPD man hours, so that both the surgeon and the patient can have peaceful nights. So thank you very much for giving me this opportunity. Thanks once again.
Wonderful, Dr. Sonu. Any question, Dr. Manpreet?
I think as Dr. Sonu has beautifully demonstrated, keratorefractive lenticle extraction or KLEX has now really overtaken femtosecond LASIK and become very safe in terms of a smaller suction time, less incidence of complications, and better post-op visual outcomes. Earlier we used to say that surface haze has a delayed visual recovery. When SMILE came into being, the same was said, that visual recovery is slower. But now, as your results demonstrate, with a VisuMax 800 platform, the visual recovery is as fast as LASIK. So,
Very true.
yeah.
So is it comparable to the femtosecond LASIK procedure, the recovery of the patient, visual recovery?
I would say that the recovery is much faster as compared to the femtosecond flap, because then flap can sometimes have those minimal epithelial defects, but with this hardly, the smallest incision that we take is 2 millimeters. So with this 2 millimeter healing, day 1, within 6 hours, the epithelium is healed. So the next day follow-up after 8 hours, the patients are 6'5" or close to 6'4", and they don't have any symptoms. The most amazing thing is the rapid recovery, and I think that is basically because of the energy adjustments that we have on the 800 platform. And secondly, the dissection has to be so smooth that you don't actually create any interface edema. So the interface remains crystal clear on day 1.
Wonderful. Thank you, Dr. Sonu. You are a great surgeon, as we all know. And I will request Dr. Manpreet for her talk now.
So I think I'm
Well,
the
this
right
wish-
person to follow Dr. Sonu, because I'll be talking about circle.
Circle.
So we have firmly established KLEX as a
Sonu,
established procedure
may I
in the
request Dr. Sonu
armamentarium
to
of
come?
refractive surgery.
So, Somshila, you also
we
come.
have, in a sense, moved from the flap to the cap, but then sometimes you do need to move back from the cap to the flap. So how do you do so? So circle pattern gives you an option to convert the original SMILE cap into a complete flap. I'm sorry. Yeah, so what we have, this is the SMILE lenticule and with the overlying cap, and if you have to convert it into a flap, you do a circle pattern which you can lift into a complete flap. So what does the circle pattern consist of? A junction cut, which is the junction between the original SMILE interface and the new flap. A side cut with a hinge which is created around the new incision plane, and a lamellar ring, which is an incision plane at the encircling the original cap cut at the same depth, but beyond it in circumference. So if you look at a cross section, if this was the original SMILE interface where my arrow is, this is the junction cut that is joining this new lamellar plane to the interface through a side cut through the external cornea. So 4 patterns were described initially, pattern A, B, C and D. So pattern D creates a lamellar ring adjacent to the smile pocket cut at the same depth as the initial cap. A is a side cut only. So if this is the original smile interface, A is only a side cut. So this will be useful when I go on further for the indications of this pattern. So Riao et al. Did the landmark study and compared these 4 patterns. So what they established was that pattern D, since it creates a lamellar ring adjacent to the smile pocket cut at the same depth, it is the most optimal pattern with the easiest flap lifting in cases of post-smile retreatment. So for retreatments and enhancements, what is recommended is pattern D. And I will also discuss an extrapolated use of pattern A. So what does the flap do? The flap thus created can be lifted to perform enhancements and retreatments. In case you have a completely retained lenticule, which all of us experience in the initial learning curve, you can lift a flap and peel off the lenticule. Then a rescue procedure when there is an inadvertent operator error or suction loss during the end in smile or error during LASIK flap creation, pattern A can be used as a rescue mode. So what's the advantage? Why not just do a femtosecond LASIK if you have to retreat? Because this circle pattern utilizes the original smile interface. So there is no risk of multiple dissection planes being created. And you can also extract a totally retained lenticule. Why not a surface ablation? No risk of post-operative haze. On the flip side, as you have moved back from the cap to flap, you have all the flap-related complications to contend with. So just to demonstrate how to apply the circle pattern in your clinical cases. So this was a 27-year-old female who underwent both eyes smile for 5.75 and 60 diopters refractive error respectively. Post-operatively, she gained 20/20 visual acuity. Manifest refractions at 2.5 years in the left eye showed a minus 1.25 diopter sphere with a 0.5 diopter cell at 140. So we planned for left eye enhancement in this stable residual refractive error, a regression, using the circle pattern. So what are the parameters that you keep when you plan a circle pattern? The lamellar and side cut diameter is 8 mm, depth is 115 microns, side cut angle is 45. For the hinge position, we kept a nasal hinge, junction cut. The diameter is the same as the original smile cap cut diameter. And the lower and the upper depth include a offset of 15 microns or so from the original cap depth so that any variation can be taken into account. So just to compare, the cap diameter was 7.2 initially, so your circle diameter has to be larger, so it's 8 mm. Thickness of the cap was 120, so ideally the circle depth should be 120 if you are retreating at the same time. After 2.5 years, there is some stromal compaction that takes place, and we did an AIOCMT3 preoperatively and saw that the cap depth now was 115 microns. So don't go blindly by the nomograms. You have to see that if you are retreating at 2-3 years, your cap depth is going to change as opposed to an immediate retreatment. Then how do you decide the incision position, angle, etc.? In this, the hinge, since the smile incision is superotemporally in the right eye and superonasally in the left eye, you can change the position of the hinge to a nasal hinge. So in this, it was 180 so that it does not come anywhere near. Then the lenticule optical zone was 6.2. So this is where your junction cut will be, because the junction has to join to the original lenticule cut size. So the diameter of the junction is 6.2, and the lower and upper depth includes an offset of 15 microns, so that even if you are slightly off than measured, you will be in the same lamella. So just to demonstrate the surgery, docking is uneventful as in any case of Visumax, LASIK or SMILE. It's a soft suction based on accurvation. After that, the laser pattern, as you see, will create a beautiful ring around the original cap interface. And there is a nasal hinge in this case, as you can see. So it's just like lifting a LASIK flap, you just delineate. And as you can see, when we cross over from this lamella towards the center, it's a seamless transition. There is no difficulty in finding the original cap interface, and there is no forceful dissection or release of adhesions. This is what is the advantage of doing a circle pattern, that you can convert the original cap into a flap without having any risk of multiple interfaces at all. After this, once you lift the flap, it's all standard excimer laser ablation, after which you refloat and reposition the flap. So this is nothing special, excimer laser ablation, and you can. So this is a second case in which what was done was that the optical zone that was selected was inadvertently larger than the cone size. It was a small cone being used. So a stromal bed is created, but a side cut cannot be created because the flap data was kept to be 8.7. And if you go beyond 8.5 with a small suction cone, your side cut will not come. So there is no side cut in this case. So what to do? Pattern A was used as a rescue procedure in this case in creating side cut only. I'll just show, sorry. So only a side cut was created. So we already had a bed cut, and only a side cut using pattern A helped rescue this surgery in which we didn't have to wait for a later date. In the same sitting, we could easily lift the flap and do the further excimer laser ablation. Same happens when you have suction case just towards the end of smile procedure and only the side cut is left to be created. At that time, sometimes the rescue mode of smile does not work. You cannot restart from there. And then also you can use circle pattern A and create a side cut instead of the whole circumferential side cut. Just select a 2 mm incision and you can create a side cut in that case as well. So just to summarize, it's an excellent option for post-smile enhancements, retreatments, and retained lenticule removal. Pattern D is the most optimal. Lamellar cut, the diameter has to be larger than the cap cut. Depth, same as smile interface. If you're retreating after 2-3 years, please recheck the depth of your smile interface with AIOCMT. Hinge cut, position can be superior or nasal. Junction cut, the diameter is the same as lenticule cut. Keep a 15 microns offset up and down from the smile interface to account for any errors in your measurements. Thank you for a patient hearing.
Very nice talk, Dr. Manpreet. So, I mean, your number case 2 was similar to what I actually had. One of my consultant was operating and accidentally she put in 8.5,
Yes.
not realizing that it's a small size and there was no side cut. So instead of circle, I think what she did was she again took a flap and just, aborted that,
But that you can wait and again creating the bed cut, why do so? That would not
so
be advisable.
she just aborted the bed cut and she just took the side cut
Yeah, that
on
can
the flap. So, I mean, since we're working in a private system, the cost varies. So,
No, it's a circle actually in the same sitting, same interface, just redock and rescue with circle. Nothing else to be done.
but the cost
Don't
of the
It only works, you already have a PI on, na? You have already done the flap.
correct, but the
This one-
license costs, the circle is much costlier than a flap. So, in practice, you have to, look
Okay,
into
that aspect,
because
it's going above me because I don't think I even
You're
realized that you're paying for the
You're
license as
privileged.
well. Yes.
So, excellent talk.
Thank you so much.
Thank you.
sir.
Thank you. This is not us?
Next, you call Dr. Somshila.
Somshila, you go for then.
Aditi is here? Yeah.
Rahil थोड़ा है? Is Dr. Arnav Singh Arnav around? Dr. Rahil? Bye. So we have Dr. Aditi Agarwal and she'll be talking on heroic, what's that? Heroic saves of refractive surgery. Excellence. All to you.
Slides are not going forward. Yeah, there it is. A very good evening to everyone. In the next 6 to 7 minutes, I will be let's delve into this very important topic of post-refractive surgery mishaps. Given the excitement around refractive surgery these days, all the attention is on doing various kind of procedures. but accidents do happen. And we should all be aware of knowing how to tackle them when it can happen to any one of us. So I'll be presenting some case clinical scenarios. So this was a 28-year-old male who underwent LASIK 4 days back. He came with complaints of pain, redness, and blurry vision on day 4. He was absolutely fine on day 1. His vision was 6/18. There were presence of multifocal infiltrates, 3 of them as you can see here around 1 mm in size. Another 3 were still smaller, less than 1 mm in size. We advised for scraping for microbiology, however patient refused and we had to go ahead with empirical therapy. However, on day 6, that is after 2 days, infiltrates had increased in size and number. Now this was really a frightening situation. The vision had dropped to 6/60. So this time the patient was convinced. We went ahead for intervention. We lifted the flap, scraped off the infiltrate, sent for microbiology, and it turned out to be a combination of GPC and KOH revealed fungal filaments. So the patient was put on fortified vancomycin and natamycin drops. Lucky here that we landed up with a BCVA of almost 6/9 at the end of 4 weeks. This was another case of trauma-induced post-LASIK infection. She was a 26-year-old female who had a broomstick injury around 5 months, few days back, and she had a LASIK around 5 months back. As we can see here, there was a broomstick foreign body lodged in the interface with a partially torn and folded flap. So the intervention was to lift the flap, thoroughly wash it, and we thought that that would have been enough and we could have just won the battle by just removing it and thoroughly washing it off. However, she got infected as expected. Microbiological examination again this time revealed a fungal with GPC. She was treated with topical natamycin and fortified cefazolin, responded very well to medical treatment. We were lucky once again. She landed up with a reasonably good vision of almost, this is covering it, around 6/9 with efforts. This was another case where there was a torn flap with epithelial ingrowth. So this patient had an RK around 15 years back, and then 3 weeks back she had underwent LASIK somewhere. She came to us with this flap complication where you can see one of the LASIK flap torn from the RK scar, and there was also a dense central epithelial ingrowth. So at this point of time, the various intervention options were either lift the flap, remove the epithelial ingrowth, do a YAG laser to stop the ingrowth, try and use an RGP or a mini-scleral lens for better vision, a PTK, or maybe a lamellar corneal surgery. So however, here as we can see in the AIOCMT, the lesion was too deep for PTK and too superficial for DALC. So we thought of doing some literature review here, and then we thought of going ahead with superficial anterior lamellar keratoplasty. And there were multiple reports in various scenarios like trauma-induced opacities and also for certain dystrophies. So finally, we decided to go ahead with this. So as we know in SALC, we basically create a free cap from the donor tissue, and the same is done in the recipient as well. And then the free cap created from this donor tissue is used to replace the thick free cap of the patient's cornea. It is important to be sure here that you can also mark the surface so that you don't miss the orientation of the flap. We used a letter S to mark this. And after the flap was taken, it was carefully apposed. We did not use sutures here, though there are reports where they have mentioned that sutures may be used to prevent epithelial ingrowth later. Somehow this patient did well and we did not use any sutures here. Results were great. The vision improved to 6/9 and we were very happy with these results. So as you can see here, the AIOCMT pictures in pre-op and post-op, the patient did really well. This was another case where there was a dense epithelial ingrowth, poor vision of 6/12 mainly because of irregular astigmatism, and we decided to intervene here. So decided to lift the flap, debride all the epithelial cells from the stroma as well as undersurface of the flap. It's important to know that debriding, when you debride this, it has to be done from both the surfaces, from the stroma as well as the undersurface of the flap. And many a times, as you can see here, the entire epithelial sheet can actually be removed in toto. And the patient did well. Patient achieved a best corrected vision of 6/6. The last case, this was a 27-year-old male who underwent femtolasic 3 weeks back. He came with complaints of blurred vision along with halos for 1 week with progressive worsening. IOP was 19, and as per him, he very clearly said that he was absolutely fine for around 10 to 12 days post-LASIK, after which he started developing this hazy vision. He was on antibiotic steroid combination. Slit lamp examination revealed presence of significant diffuse whitish granular infiltration, quiet AC, and a normal looking fundus. So we thought this was a DLK, there's no brainer, we just stepped up the steroids. However, the patient came back with worsened vision after 3 days. The vision had dropped to 6/18. IOP had raised to 28 in both eyes, and slit lamp findings had also worsened. So we decided to go ahead with an anterior segment OCT here, and here as we can see, it showed the presence of some interface fluid, which appeared like a tiny fluid cleft in both the eyes. So this was actually, we were dealing with PISC, which is pressure-induced interlamellar syndrome, keratitis, or interface fluid syndrome. So the slit lamp findings and the visual degradation are almost like a DLK, but important to know here that the onset is beyond the first week. So the take-home message is, if there are problems, there are solutions. Accidents will happen, but we need to know the right techniques and options to come out of it. Thank you so much. Thank you.
Excellent presentation, Aditi, and definitely very heroic saving the situations. I think the use of OCT in all these complex situations is a very useful tool, also in the case where you have epithelial ingrowth, because you see a very high reflectivity in the OCT, and that helps you identify, because like you said, that the sheet is way beyond where you think you can clinically see. So there are sheets of cells, but the reflectivity, because it's so different for the epithelium, you can pick up on OCT. So you know how far back you have to retract the flap and remove debris. And the second point I had was about interface fluid syndrome. So whenever if I see it looks very similar to DLK as you mentioned, but if it's involving the area beyond beyond the flap, so that's an automatic clue that it is not DLK, that's one way. And of course, in week 2, you usually see DLK very early, and week 2, when you see DLK, then you kind of think, could it be something else, as you did in your case? And of course, one needs steroids and one you should not be using steroids because that's a cause. Very well presented.
So I just wanted to add on, for the epithelial ingrowth, do you actually use some kind of alcohol or mitomycin, or just simply scrape off and just put the flap back? Okay, because most of the cases, if the epithelial ingrowth is there and you just remove, so it might come back again. Yeah. So
you may not use mitomycin, but definitely use alcohol to kill any cells, because epithelial cells their pluripotency is well known, and they survive for a long time. So you'll have small nests which can grow. So it's always better to use alcohol, 20% alcohol for 20 seconds or whatever. There's no normogram for it, but at least there's no harm done in using it. We've not seen any toxic damage or anything.
So thank you for that wonderful talk. And now I invite Dr. Arnav, and he'll be talking on Smile Extra.
A very warm good evening, everyone. My topic for the presentation is Smile Extra procedure, an advanced approach integrating lenticule extraction and corneal cross-linking for refractive correction. So refractive surgery in myopic patients with high refractive error, thinner corneas and borderline topography is a very challenging decision, with the most feared complication being regression and post-op ectasia. Collagen cross-linking, effective modality to strengthen and stabilize the cornea in borderline cases, keratoconus and ectasia after refractive surgery. Relax Smile, when combined with cross-linking intraoperatively, further prevents the risk of future ectasia in susceptible individuals. Hence, this study was undertaken to observe the safety and efficacy of visual outcomes following Smile Extra. It was approved by the Institutional Ethics Committee and adhered to the tenets. The inclusion criteria was age more than 18 years, altered topography in susceptible cases, stability for about a year, BCVA of 6/9 or better, up to -10 diopter sphere and -5 diopter cylindrical, and central corneal thickness of more than 450. The exclusion criteria were unstable refraction, significant ocular diseases, previous corneal surgery, autoimmune diseases, subjects with a corneal thickness of less than 450, and established keratoconus or a hyperopic refractive error. All patients underwent a thorough preoperative clinical examination, which involved slit lamp biomicroscopy, manifest and cycloplegic refraction, dilated fundus examination, topography, aberrometry, contrast sensitivity, dry eye assessment, and the uncorrected and distant best corrected visual acuity. How we actually proceed for the procedure is first the VisuMax femtosecond laser was used to create a refractive lenticule with an optical zone of about 6 to 6.5 mm and a cap diameter of 7 to 7.5 with a thickness of 120 microns. This was followed by a lenticule dissection, which is extracted through a 2 or 3 mm incision, followed by the removal of the lenticule and injection of 2 ml of 0.1% riboflavin solution injected into the interface and allowed to diffuse for about 60 seconds. This is washed and followed by accelerated cross-linking with UVA radiation performed at 365 micrometer wavelength, 30 milliwatts per second centimeter square for about 1 minute 54 seconds through the cap. The total energy remains at 3.4 joules. So the extra procedure involves lenticule extraction with 2 ml of 0.1% riboflavin diluted injected into it, and our protocol, what we follow is UVA radiation of 30 milliwatt. These are the parameters which are fed into the machine, and we follow it for almost all patients we have done so far. The follow-up was done at day 1, 1 week, 1 month, 3 months, 6 months, and 12 months post-operatively. The recordings of uncorrected visual acuity, slit lamp examination and topography documentation will be discussed thereafter. And clinically or topographically, none of the eyes showed signs of regression or post-op ectasia. As we can see, the right eye and the left eye shows very minimal interface on day 1, roughly grade 0.5 according to the Fantes et al. Criteria. On the slit lamp examination as well, we can see there is very minimal interface. This is the AIOCMT3, which shows the demarcation line. The post-operative medications are almost as regular for the other patients with a little bit of steroid cover. So lubricants we prescribe about 6 to 12 times, preferably 12 times for 4 to 6 weeks as the patients complain of more dry initially, followed by topical moxidexar combination 6 times for 1 week and then tapered every 1 week. And 0.1% prednisolone on an hourly basis for 4 days. Cyclomune is also given in these patients. Coming to the results, we did about 38 eyes of 19 patients with a mean age of about 25.2. Mean follow-up was about 6 to 12 months from the date of surgery. And long-term studies so far have shown very promising results. All patients were comfortable with no intraoperative or postoperative complications. These are the statistical parameters that were taken and the tables. Coming to the discussion part, adjuvant techniques that use collagen cross-linking during laser refractive surgery have been proposed as a solution to maintain the structural integrity of the cornea. With promising results, PRK and LASIK combined with rapid cross-linking have been used to expand the pool of candidates which can be operated for SMILE as well. Based on the few studies done before, we took a step further and did it for SMILE Extra. Thank you.
So, Dr. Sonu, you also do a lot of SMILE, but do you also do SMILE Extra?
So I have a very limited experience for SMILE Extra, and yes, I think that's a way to come up for those kind of borderline corneas where actually you don't want to shift to phakic lenses, and you have borderline corneas and which can be fixed by doing this. So the only question that I wanted to ask was, what is the day 1 picture like? I mean, how much is the inflammation that you see? How much is the interface edema or interface haze, or as normally the cross-linking would lead to?
Yes, sir.
So what is the day 1 to day 7 kind of profile that you have, actually?
So most patients that we came across, not more than 0.5 to 1 grade of haze, and which settles by the 3rd day itself, but usually we keep the patients on a follow-up of 1 week or later. And mainly, we do come across this question, why don't we prescribe these patients a phakic ICL option? But usually for an intraoperative procedure, they take a back step, and then we do end up telling them, okay, you do have an option of SMILE, but you have to be either on constant follow-ups. For patients who cannot be on regular follow-ups, we do give an option, okay, if you can go for SMILE Extra. That has served all patients so far, and even I have done for about, we have data of about 1 year. There has been no long-term haze at all, and patients are doing 6/9 or better.
apart from those patients who are unfit for phakic ICL also fall into this category, because there are a lot of patients with borderline ACDs like 2.7 or 2.78, where we actually would not like to shift them to phakic lenses. So there I think this also comes into play.
Yes, sir.
So we did multiple cases only on those patients who were like borderline corneas and phakic ICL unfit, and they were doing very well.
Yes, sir.
Can I have a just look on the quick slide of
Yes, sir.
what is the nomogram, the riboflavin concentration
Yes.
that you showed? Can we have his presentation?
Yes.
We have enough time for discussion, so for the interest of the audience. Yeah, exactly.
So this one.
No, the slide back. One slide back.
Okay.
Where you, yeah. So it's the, which riboflavin are you using? Is this the
So the ribocross.
ribocross?
And this
And
is
you-
a parameter
and you-
that is
Soaking time, you
kept
keep it for 60 seconds?
1 minute 54 seconds.
No, that's the soaking time. 1 minute.
1 minute 54. And the post-op findings are almost in all patients, we've had a similar picture, 0.5, 1 maximum.
Okay, thank you. Thank you for that wonderful talk. So I would like to now to invite, no, Dr. Mahipal nahi hai, is Dr. Rahil around? Dr. Rahil Chaudhary? Anybody from I7 to talk for him? No? Dr. Mahipal, sir, I think he's there in the OPL. So we have Dr. Somshila, and she'll be talking on the complications of phakic lenses. A great surgeon, a great academician, member scientific committee, director for LVPI Hyderabad, Bombay, and a great friend. All to you, Dr. Somshila.
A very good evening, and the great friend is the reason for that wonderful introduction. Thank you. So I thought we'll shift gears, and also because mine was the last topic, so I thought it'll be very boring if I stretch it. So I'm going to try and keep it very brief, and also talk about heroic saves of complications when you face in phakic IOL. So, but just a disclaimer is that on the whole, use of phakic IOLs are very safe and extremely effective. Of course, you should have the suitable patient, and it has a short learning curve. I always feel that a good cataract surgeon can very easily master this technique in terms of the surgical part, and also the preoperative workup. Those are some important points that we need to learn. But if all of us were able to figure out A scans and what kind of biometry and so on for a cataract surgical patient, I think phakic IOL can be adapted very easily in most practices. But like any surgery, it's going to have its interesting points like intraoperative, postoperative complications. So be ready for that as well. So I'm not showing videos because day one I had a lot of challenges with my videos, so I just decided to just show you a few patients and just discuss some of the problems that you can have. So as you know now, we also have phakic IOLs for hyperopic patients. So myopic patients, I think most of us are using it, and it's literally very simple, and most of us have good outcomes. But when you use it for hyperopes, then as what Sonu had mentioned, that anyway the hyperopic patient would have a shallow anterior chamber, as we all know, and the vault of the lens is very critical. So I had a patient who this was the refractive error for this patient, very interested in phakic IOL, and the ACD on oculizer that we used those days was looking fairly good. So I thought we can go ahead and use hyperopic phakic IOL for this patient. But the vault was quite high, which is okay. 638 is not a bad vault, but unfortunately it was shallowing the anterior chamber extremely. So shallowing of anterior chamber or a mismatch in the size is one of the problems, or you can say complication that we face. And this is how the iris was tented up in the anterior chamber and crowding the peripheral angles. So what was the answer for that? We did a surgical PI which is recommended for hyperopic. That wasn't helping much. So for the other eye, because I don't do simultaneously, other eye, we reordered the lens and we could use a better vault for the other eye. So this was the left eye, which was doing okay. The anterior chamber depth was not too bad. And in the same patient, we also had an optic capture because the vault was so forward. So I had to exchange the lens for one eye, and the other eye did well. Coming to another problem is decentration. There are various reasons for decentration. One unexpected reason in this case was, we found out later what could be the cause, is that this was a 29-year-old, very fussy patient, underwent sequential phakic implantation. My colleague had operated, and on the first post-op day, the phakic IOL sank, the heart also sank, because we knew that the patient is now going to be super unhappy. And so immediately my colleague repositioned the lens. The next day after the repositioning, or the evening, again, it had just decided to sink back. Perhaps, we should have waited and tried to figure out what was the reason, why was it sinking in the first place, because all the parameters were good. So what should we do? The patient wanted to get back to work very fast. So instead, we had no other option but to do an exchange. And incidentally, the other eye, we did an uneventful phakic IOL for this patient with the standard parameters. So what was the reason for this problem? So this problem happened because, which we could discover later on UBM, is that the patient had a sort of a weak zonular dehiscence inferiorly, and those are not letting wherever the ICL was hanging in the eye, the phakic IOL was hanging in the eye, it was not letting it stay centrally. So you can have very unexpected causes for decentration, apart from iatrogenic or what we do in the eye. Flipped phakic IOL is not uncommon. All of us probably in our careers must have had a close miss of a flipped IOL, or would have actually had it. So what happens with flipped IOL is that the vault is now literally zero. At least there's literally no space between the lens and the natural crystalline lens. So here we had a patient who had vision was extremely good. One eye was also fine, but in the other eye, the IOL was flipped. The ICL was flipped, and it was touching the natural crystalline lens, causing a focal cataract. What should we do? So the patient was not unhappy at this point. It was 4 years post-operative, and so we actually just observed. We left the patient alone, and she was lost to follow-up anyway. So sometimes you can have a flipped phakic IOL, which will cause problems. Sometimes you can have it's not causing problems. Especially, you can have iris chafing. That's a very bad problem that you can have, really problematic. There you have to absolutely remove the eye explant and then place a good one. So this is one such problem where we had a patient who had undergone sequential phakic IOL implantation. The patient, immediate post-op, what we got from the papers was that patient had very high secondary glaucoma, so we assumed must have been a pupillary block. And when the patient came to us a few weeks later, we saw that there was literally like a caking, like a painting of the phakic IOL with iris pigments. And the pupil was mid-dilated and fixed like this. And we were wondering that the cause of the raised intraocular pressure was obviously because all these pigments had dispersed and blocked the angles, as well as caused a pupillary block. And that's why there was such high pressure. So first of all, we controlled the glaucoma colleagues helped. And what we saw on UBM is that there was a large area of contact. So this is where all the IOLs, where do they contact the iris? They have 2 points. They have a point where they're contacting the back of the iris, as well as they're resting somewhere in the zonules, somewhere at the edge of the crystalline lens. So we don't really know yet where they are. And here you can see the vault is very minimal in the initial postoperative. So this was causing chafing when the pupil was dilating, constricting initially in this area in both the eyes. And that was the cause of the pigments. So we waited, the pigments slowly went away. However, the patient developed cataract in both eyes and underwent sequential surgery. So we had a good result for this patient. She recovered good vision in both eyes. She did have PCO. This was just the cataracts. So we managed that particular patient well. So remember that if you flip the IOL or for some reason the vault is very, very low, so you can have secondary glaucoma in these patients. Cataract is not uncommon because these are high myopes. We have to differentiate between cataract that could be caused due to touch, like this particular focal cataract, or nuclear cataracts, which can develop in high myopes. They can sort of push it onto you that the surgery has caused. In refractive surgery, anything that happens to the patient for their lives is because of the refractive surgery that we did for them. That's what I've noticed. So here also they usually have that opinion, so we have to just push it across saying that high myopes, the incidence of cataract is much higher. And this was, again, a doctor who presented day 1 post-op with this very severe AC reaction. We thought that it must be endophthalmitis. So remember that just like any other intraocular surgery, you can have infection, so not to be taken lightly. I agreed with the previous speakers who said that, patients don't want an intraocular procedure Rather, they'll have a surface procedure. And this is, even I'm happy to do a surface procedure over an intraocular procedure. And so luckily, this pediatrician did well. We immediately managed the case, and the other eye was done by us, and she achieved good vision. Sometimes you can have minimal trivial, so don't do bungee jumping. I heard that in Rishikesh or somewhere there's bungee jumping. If you have a phakic IOL, please don't go for bungee jumping. This is one such patient who had traumatic subluxation after bungee jumping. And so I always advise my patients no bungee jumping after phakic IOL implantation. And this is after. So in conclusion, of course we pay attention to sizing and we pay attention to surgery, know the technique, so don't flip the lens. But ultimately you have to figure out if there's a complication, how to deal with it. Thank you very much.
Thank you, Somshila, for that wonderful basket of the complications that you showed. I think it was an entire gamut of the phakic IOL complications and wonderfully managed. So, I mean, I think me and Gaurav also shared the second last case that you showed, the inflammation, correct? So, I think that was something kind of a uveitic kind of secondary glaucoma, and then ultimately landed up in extraction, the eye cell removal, yeah. So, thank you very much. We have Professor Dr. Mahipal Sachdeva, Director, sir.
So we used a larger diameter. We went 0.25 or 0.5 larger on the previous one, and then we prayed.
Thank you.
Thank you, sir.
I'll be talking about innovations in Calyx, and those who are sitting for the quiz, Calyx is now the word that is being used for keratolenticular extraction. So that is the keratolenticular extraction surgery, which is all silk, smile, etc., everything. So it's basically the lenticule that is extracted. So whenever you are looking at Calyx, the basic concept is that the laser passes in 4 steps. So first step is the posterior step of the lenticule. Second is the round cut. Third is the anterior, that is called as the cap. And fourth is called as the entry cut. So this is how you actually go about it. And these are the lasers that are available today commercially. So you started with about more than a decade ago, the Visumax 500. The Visumax 500 now has what is called as Visumax Pro. Sonu is one of the users, so this is Visumax 800. You have the combo unit of cataract, femtocataract, plus the flap, plus the lenticule in Zimmer, and you had what is called as the ATOS in Swindt, and you have the Elita, which is with Johnson & Johnson. So these are the things that are available. You can see that they all have 1043 and or around that. The pulse repetition rate changes, and you can see that the fastest laser that you have is the Zimmer, which is 20 megahertz, and then you have Elita, and the energy per pulse you can see is the lowest, which is in the Elita. So basically how fast it is, how much is the energy that is going in, and the total time that is taken for the lenticule to be formed is 16 seconds here, and it is about 10 seconds there. So the fastest, that means from the time taken, is the Visumax Pro, followed by the Elita. Most of them have either a curved or a flat interface. The Zimmer and the Elita have flat interfaces. The earlier problem in the 500 was that there was no cyclotorsion compensation or inbuilt centration. That means after you have docked, if the centration is off, you cannot do anything. You have to release the dock or do it again. And if there is a torsion which you have, then the astigmatic correction will not be there. But majority of the other systems, even the new Visumax, have now this. Now, the first thing is, what are the innovations in lenticule extraction? These are what I am going to talk about. So first is the improvement in the dissection technique. So over the years, there are people who have described, so this has been described by Tityal and Manpreet et al., which is called as the meniscus sign. So what exactly is the meniscus sign? So when you are going in the posterior lip and you have already dissected the anterior lip, you get something like a lip. Okay, so this is like a meniscus. You can get a meniscus both at the when you start, or you can even get the meniscus at the bottom. So this is when you are in two different planes and you are dissecting the posterior plane that you get the meniscus. Now this is called as the white ring. You can see this. This is the white ring, and this white ring again was described by Susan Jacob. So this is that shows that this is the ring which is where the lenticule margin is. Now this has been described by Gitansha Sachdev et al. And this is called as the stop sign. What does stop sign mean? See, basically you have to go in two different planes. This is one plane, this is the other plane. Now when you come into this size, can you see that there is a stoppage? So that means that you are in two different planes. If you were in the same plane, you would not get a stop sign. So this is called as a stop sign. Now, what we have also described is called as, we are using innovative uses of lenticule is tailored stromal expansion. Nowadays, there are machines which are giving you less fluence for cross-linking. Okay, but previously it was 460 was the cutoff point that you don't want to do a cross-linking below a thickness of 460 because you remove the epithelium and then you can cause endothelial damage. So you had to artificially increase the thickness of the cornea. So one was hypotonic, riboflavin was used, that would swell up, or Susan Jacob described putting a contact lens. But these suffered because the fibers in a hypotonic would spread out maybe in a different manner and you wouldn't get the effect to that effect. Contact lens was a fixed power. So what we described was in the use of taking a lenticule. So supposing I have a smile or a silk patient, I have a 2 diopter or a 3 diopter, then I am taking 13 microns, so I have a 50 or a 60 micron lenticule that I can put on the cornea, do the cross-linking and then remove it. Okay, so I can actually tailor the stromal expansion. So I am expanding the stroma for the time of the cross-linking, but tailoring it. So if I have to add, say, 100 microns, I will look at a patient who has a 6 or a 7 diopter or something around 7 into 13 plus the table, so that will be 100 microns. So this is tailored stromal expansion. You just to show you on a video, you remove this thing, epithelium. This is the smile procedure that has been done. You have taken out the lenticule and you are placing it, and it fits over the cornea where the thinnest part or the steepest cone is or the thinnest cornea is. So you can actually see as to what you are expanding. The other important thing is that it is not UV radiation going through a contact lens and stroma. The penetration is going to be through stroma and stroma only because it is either a donor stroma or it's this thing. So you can peel it off later. Now this is retained lenticule. So sometimes you can have a retained lenticule. If you do a topography post-operatively, you can see it, but the best way to see a retained lenticule is to do a retro-illumination. You can also do an OCT, intra-op OCT, or you can do an OCT post-operatively, or the other simple way is to either hydrate. So in case this is a lenticule which is retained, you can see that we are going to, you can also do illumination from the side. You can see there is a lenticule that is retained here. Once you have taken out the lenticule, you will be able to see that it is not a complete lenticule, but if you hydrate it well, just see, this is the lenticule that is being taken out, and this is the portion where you can see that the lenticule is incomplete. Okay, so this is an incomplete lenticule. Always spread it onto the cornea to see where it is incomplete, and then you can go on the slit lamp, or what has been described is use triamcinolone. You can use triamcinolone and you can see as to where the lenticule is, and then you can demark it and remove it, or you can use the intraoperative OCT, or you can use an OCT later on. So this is again on the OCT that you can see where there is anterior, posterior, and there is the retained lenticule, edge of the lenticule, so you can actually take it out. Now, other innovative use of the lenticule are intracorneal ring segments. You know that for keratoconus or ectasia, you use a PMMA ring segment, which is called as Intax or Kera rings. But Susan Jacob has described the use of parts of the lenticule or the cornea to be put like the same. She calls it as Cares. So this is something that has been described. Philly has been described for hyperopia correction. So if you make a pocket, You take a prefixed minus say 3 and you can put it into the pocket and that will create, that will cure hyperopia. Sri Ganesh has shown this. Also, Philly has been used as an innovative use of the lenticule for keratoconus because you are supplanting tissue and there is a flattening of the cornea. So friends, this is what I just wanted to tell you. These are a couple of signs for improving the dissection techniques. The centration now can be done whether manually or automatically for cyclotorsion compensation, and centration you can see, and these are a couple of the uses that I have told you where the tissue can be used. It has also been used for perforations, etc., small perfs, etc. You can use this particular tissue. So this is, I would say, the lenticule extraction is a technology, apart from giving good refractive results, is also possibly going to have a lot of uses for the future. So I would say the world of refractive surgery, lenticule extraction is undergoing drastic changes. Current platforms have upgraded and upcoming ones on the horizon. And these updates have attracted more surgeons to shift to lenticular-based procedures with comparable results or even better results as compared to flap-based procedure. No flap-related composition, possibly better biomechanical strength, less dry eye and less induced abrasions. I think refractive lenticule is here to stay. Thank you very much for your kind attention. Thank you.
Thank you, sir, for that wonderful talk. A quick question, what is the percentage of your flap-based vis-a-vis lenticule-based or CLEX surgeries?
85% is lenticule. I don't know the exact percentage, so I do flap only and only in case I have a compound number or I have a hyperopia or I have to do a redo. That's all. Otherwise, I always prefer to do, and my upper limit is -10. Then I go to ICL, or thin corneas, I go to ICL.
So I think that speaks from the domain of ophthalmology and refractive surgery that lenticule is in and is the, the main way to go for any kind of refractive correction. Am I right, sir?
Yeah, sure enough. That's where I have shifted. We have about 7, 8 of lenticule
So any
machines.
quick question that we can have, because we are overshooting time, and we're sorry, Dr. Krishna Prasad, is he around? So yeah, please.
Come, all
For
yours.
the quiz, all yours. Any
You can ask questions also, Prashant.
Any
don't
question to
worry.
Dr. Mahipal? That can be a part of the quiz program as well.
Chalo. Who did the first smile procedure in the world the way it is being done today? Anybody?
So that's the bumper prize from the quiz masters.
अरे हिंदुस्तानियों का नाम रख लेना, रूपल शाह.
So thank you very much, sir.